Hello and welcome back to the Academy of Anaesthesia. In today's video, we will be discussing the physiology of blood loss. This is one of my favourite topics as it covers a lot of physiology in the context of a clinical question. It's also a very common question in the primary FRCA. This is a 2-in-1 question as the same physiology can be used to answer the question, how is blood pressure controlled in the body? We will be discussing the different protective mechanisms that help deal with an acute hemorrhage. Firstly, let's imagine Bob. Bob has come to the emergency department as he has been stabbed and is bleeding from one of his major arteries. You assess him in the resus bay and you notice Bob is pale, sweaty and drowsy. You take some observations and they show a high heart rate and a narrow pulse pressure. He has a high respiratory rate and his cap refill time is 4 seconds. His Glasgow coma score is 13. Bob isn't having a very good day and needs urgent treatment. To appreciate why Bob has these signs and symptoms, let's take a closer look at what's happening inside him. We can divide the response in his body into 3 broad categories. These are the immediate, early, and late mechanisms. Specifically, these are the baroreceptor reflexes, the chemoreceptor reflexes, Starling's forces, his adrenal glands, the release of ADH, the renin-angiotensin-aldosterone system, and finally EPO or erythropoiesis. Out of the 3 immediate mechanisms, the most important one is the baroreceptor reflex. We have 2 types of baroreceptors, low pressure and high pressure baroreceptors. The main receptors we will be discussing here are the high pressure ones. These are located in the aortic arch and the carotid sinus, which is a dilatation in the internal carotid artery immediately after the bifurcation. The way these baroreceptors work is at normal blood pressure, they get stretched, and this causes them to send signals via the glossopharyngeal nerve and the vagus nerve. They send these signals to the brainstem, letting the cardiovascular centres know that the blood pressure is fine. However, when there's a decrease in blood pressure, they're not stretched as much, and therefore you get less firing, and this causes the brainstem cardiovascular centres, more specifically the nucleus tractus solitarius, to increase the activity of the sympathetic nervous system and reduce the activity of the parasympathetic nervous system. This leads to an increase in heart rate, contractility, and systemic vascular resistance. The signals to the heart are carried by fibres arising from T2 to T4. If you go back to the basic formulas where mean arterial pressure is equal to cardiac output times systemic vascular resistance, and that cardiac output is equal to stroke volume and heart rate, the increase in heart rate and contractility will try to bring up the cardiac output, and the increased vasoconstriction will increase the systemic vascular resistance, and both will combine to push the map up back to normal. This is the compensation you see in Bob. Of course, if blood loss continues beyond 2 litres, then Bob will decompensate and you'll see a dramatic fall in blood pressure. The other immediate mechanism that occurs is the chemoreceptor reflex. As blood is lost, the body's cells don't get enough nutrients and oxygen, and so start to produce lactate and more carbon dioxide. This leads to the blood being more acidic. The hypoxia and the increased carbon dioxide will be detected by peripheral and central chemoreceptors, where it will lead to an increase in respiratory rate and depth of ventilation. We will be doing a video on the control of ventilation and this will be covered in a lot more detail, so stay tuned for that. The last immediate mechanism is the one regarding Starling's forces. In very simple terms, in the blood there is a constant tug of war between the water and proteins both inside and outside the vessels. Proteins attract water, but if the pressure of the water is too high, then the water tends to seep out. The pull of the proteins is called oncotic pressure, and the tendency of the water to seep out is called the hydrostatic pressure. In the diagram, P stands for hydrostatic pressure, and pi represents the oncotic pressure. The little I is for the interstitial space, and the little c is for the capillary. Normally, this is kept in balance where the water slowly trickles out of the capillaries into the tissues, but when you lose a lot of blood, you lose the hydrostatic pressure of the water in the capillaries, and so it's reversed. The net movement of water is therefore from the interstitial tissues and back into the blood vessels to try and replace what's been lost. Those are the immediate mechanisms, and they were all about damage control and avoiding a catastrophic drop in blood pressure. These early mechanisms are the reinforcements that allow the process of refilling of the blood vessels to start. The main mechanism here is via the already activated sympathetic nervous system. We already mentioned how this happens in the immediate phase, but the activation of the sympathetic nervous system also leads to the release of adrenaline and noradrenaline from the adrenal glands. These hormones circulate around the body and act on adrenergic receptors to further enhance the effects of the sympathetic nervous system. Because this is acting via hormones, it takes a bit longer to take effect, and therefore it's not as immediate as the sympathetic nerves themselves. Now for the late mechanisms. This final phase is about recovering from the initial insult and rebuilding the components of the blood that's lost. The three main mechanisms that act here are antidiuretic hormone, renin-angiotensin-aldosterone system, and erythropoiesis. Firstly, ADH, or antidiuretic hormone. How the body regulates the amount of water in itself is a whole other topic, but briefly, there are osmoreceptors in the anterior hypothalamus. They detect that there is an increase in the osmolarity of the blood, i.e. there's not enough water, and this leads to the release of ADH from the posterior pituitary. However, in the context of blood loss, ADH release is triggered by many factors, including a drop in blood pressure, increased sympathetic activity, and increased osmolarity. ADH then goes on to act on V1 and V2 receptors. V1 receptors lead to vasoconstriction, and therefore an increase in SVR, and V2 activation leads to channels in the collecting ducts of the kidneys called aquaporins to form, and this leads to increased water being reabsorbed back into the bloodstream. You then have the legendary renin-angiotensin-aldosterone system that we all know and love. As a short recap, in the nephron, there is an area known as the juxtaglomerular apparatus. A fall in blood flow here leads to the increased production of renin. Renin converts angiotensinogen into angiotensin 1. Angiotensin 1 gets converted by the angiotensin converting enzyme, which is secreted by the lungs and the kidneys, into angiotensin 2. Angiotensin 2 will then cause vasoconstriction of the afferent and the efferent arterioles, primarily the efferent, and increases the reabsorption of sodium at the proximal convoluted tubule. Angiotensin 2 will also stimulate the release of aldosterone from the adrenal gland. Aldosterone will increase the sodium and water reabsorption at the distal collecting tubule, and therefore both angiotensin 2 and aldosterone will yet again pull more water back into the blood vessels. The last mechanism, which is usually missed out, but is as important as the others, is erythropoiesis. Relative hypoxia to the kidneys causes the production of a hormone called erythropoietin. I won't go into the detail here, as it's another topic in itself, but in a nutshell, this is a hormone which leads to the increased production of erythrocytes, or blood cells, through a process called erythropoiesis. Over time, this will lead to the hemoglobin normalizing. Just to summarise, we've gone through the baroreceptor and chemoreceptor reflexes, the effects of Starling's forces, the role of the adrenal gland, the effects of antidiuretic hormone and the renin-angiotensin-aldosterone system, and we even discussed briefly the role of erythropoiesis. And that's it, that's all you need to know for the exam. It is worth mentioning that if your patient is under an anaesthetic, some of these protective mechanisms may be dampened, and so the effects of acute blood loss can be worse under anaesthesia. There are a lot of physiological mechanisms at play here. I described these in isolation, but remember that they are working synergistically and have complex interactions. For explanatory purposes, and in the exam, it helps to classify them into the immediate, the early, and the late responses. The diagram I've drawn out here is too detailed to recreate in the Viva, but it's there to help you have an image in mind when describing these complex physiological mechanisms. I hope you found the video useful, and thank you very much for watching.